Excellent. So before we start, some housekeeping. Can I just welcome everyone and ask everyone to mute their microphones for the duration of tonight's presentation? And all questions and answers, or questions for the question and answer session towards the end of tonight's presentation will go through Dr. Bridget Gertzel, our excellent research coordinator. And if you can put your questions in the chat, we'll then direct them to the relevant panelists. Good evening and welcome to the Absolute Uterine Factor Infertility Information Evening, hosted here at the Royal Hospital for Women by the Royal Hospital for Women Foundation. It's an absolute pleasure to be here, and it's an absolute pleasure to have an incredible group of people to present on this unique topic. My name is Dr. Neil Kiley. I'm an obstetrics and gynecology trainee here at the Royal Hospital for Women, and I'm involved and lucky to be involved in the uterine transplant research study currently being conducted here. Tonight, I'll be guiding our discussion and ensuring a fruitful exchange of ideas, assisting during the question and answer sessions with Dr. Bridget Gertzel, who manages our research study. I would like to take this opportunity to express our deepest gratitude to the fabulous Royal Hospital for Women Foundation for their unwavering support with this research study and helping us launch this information session tonight. I can say hand on heart, we would not be able to do this without them. So Elise Jennings and her team, thank you so much again. This information will focus on the absolute uterine factor infertility, a topic of utmost significance that profoundly impacts the lives of very many individuals, couples, and their families who dream about starting a family but face the challenges of this particular form of infertility. Tonight, we're fortunate to have a very distinguished panel of experts and individuals who will generously share both their experiences, their knowledge, and insights about this journey for them. Allow me to begin by introducing our esteemed keynote speaker for this evening, Dr. Rebecca Deans. Dr. Deans holds a remarkable achievement as she conducted our very first uterine transplant here in Australia. Congratulations, Dr. Deans. Her groundbreaking work has paved the way for advancements in the field and provided hope for countless individuals struggling with infertility. Dr. Deans has also received the New South Wales Woman of the Year Award for 2023.
I think Neil may have broken up there. So I think perhaps if you wouldn't mind just sharing your presentation with the group. And we welcome Dr. Deans.
Okay, excellent. Just sharing my presentation now. Okay, excellent. Can everyone see that presentation?
We can, Beck.
Excellent. So I would just like to say thank you very much for having me speak tonight. And tonight I will be speaking about absolute uterine factor infertility, or uterine factor infertility, because now it is an infertility that is no longer absolute. There is a treatment option for it. So I think that term is starting to have an evolution. So the prevalence of this, as Neil was alluding to, so this is where you don't have a uterus, or you have a uterus that is dysfunctional. And we know that you can be born with a Mullerian duct anomaly, so that's the embryological origin of the uterus, and that's about 3 to 6% of the general population born as female. And MRKH, which is Mayer-Rokitansky-Kusterhauser syndrome, is the most severe form of this infertility, where you have a complete absence of the uterus and often the upper vagina. This is in about 4,500 women, and those women have fully functioning ovaries. Alternatively, you can acquire this condition by having a hysterectomy. So that might be because of cancer diagnosis, or because you might have lost your uterus due to uncontrolled hemorrhage of the uterus, which can sometimes occur after having a baby. So the story so far, so the concept actually started in Australia with this guy here, Mats Brandstrom, who was a fellow in gynecological oncology in 1998 at Royal Adelaide Hospital. At that time, he met a young woman, Angela, who was 26, who had cervical cancer, and he was booking her for a radical hysterectomy, which is a hysterectomy which is relatively similar to the donor hysterectomy operation. So a very wide hysterectomy to remove all the tissue beyond the uterus itself, as well as with preservation of her ovaries. She was completely desperate. She said, "Why can't you perform a uterus transplant? My mum's be willing, she's young and fit, and she could give me a uterus, and my sister's finished her family. I just don't understand why you can transplant other organs. Why don't you transplant the uterus?" And that gave Professor Brandstrom an idea. So he went back to Sweden and spent the next 12 years and more developing a very rigorous research development. And he looked at the uterus transplant in animal models first, which is often what you will do for drug testing or any sort of scientific testing before you move on to experimentation within the human model. So he went through the mouse and was able to achieve a pregnancy and live birth in a mouse. And then they developed the surgery within the rat, the sheep. They did transplants within the pig, and then they moved on to non-human primates. So that's like monkeys within Africa. I went to visit him in 2010 when he had just received ethics approval to move on to do the uterus transplant in the human. And he had just come back from his trip from Africa, having completed some transplant surgeries there. And during all of these developments, they really honed down that surgery to really make it as safe as possible for humans now. And it is the operation that we do today. So then to move on to human studies, there were 2 early attempts prior to Professor Brandstrom's research protocol. There was one in 2001 in Saudi Arabia, and then one in 2011 in Turkey. Both had failed and were unable to have a live birth at the time of Professor Brandstrom's study. And then he then moved on and did 9 human cases in his first trial. They had mainly MRKH, and all of them required IVF prior to their transplant, with a minimum of 5 embryos at day 3, which were frozen. And now they've moved their protocol up to 10 day 3s. And then they also underwent extensive preclinical inclusion and exclusion, sort of screening, and then psychological assessment. And this is a slide to show the number of cases performed around the world, and it really has developed from Sweden, and there have been a lot of cases performed within Europe, and then the Swedish team have then gone over and trained some teams in America and other parts of the world. So from that idea that came in from Adelaide and then was developed further in Sweden, we now have the information that we have today. So what has resulted from that early study is that there have been more than 90 transplant procedures performed, and there's more than 50 in the last 5 years. So there's a real exponential growth in interest in this. And whenever I give this presentation to groups of doctors, I always say that in my experience, the reason for this is it's very much patient driven. So my background is a pediatric adolescent gynaecologist, and I had a long history of treating patients with MRKH. It was a patient who said to me, there's a team in Sweden who are doing transplant, and that's why I went to visit Mats Brandstrom. And it's the patients that have always come back to me after their diagnosis with MRKH, always coming back to me saying, I'd love to hear about this more, because clearly there is a need, and women feel a very great desire for this, or, people without a uterus feel a great desire for this procedure. And that's compared to other what we call ephemeral transplants. So these are non-life-saving transplants, such as the face and the upper extremity, and you can even do leg transplants, which haven't taken on with the same level of interest. And there's a few different reasons why, but obviously the patient interest is the first part of that story. And then just to briefly go through the different approaches of the transplant procedure. So hopefully it won't be too gory. So there have been a number performed around the world, and this is data that is in the International Uterus Transplant Registry, for which we contribute our data to, and it is held in Sweden. And not all the teams around the world contribute to this, namely the Americans, who have their own database. So they tend to carry their own. So this is not reflecting of the American data, but most of the teams around the world have contributed to a grand total of 45 when this was published earlier this year. The majority are done by laparotomy, so an open cut operation, but some have been done by robotic or laparoscopy, which is keyhole surgery, and in the different types of donor, which can be either living donor or deceased donor. So there's very different techniques and different ways that this procedure can be performed. So a laparotomy is an open cut operation, usually from the belly button down to the pelvic symphysis, so down to your pubic bone, and then you put retractors in to open up to find the organ, and that's both for the donor and the recipient. There's most experience with this type of surgery. It's generally cheaper because you don't need all the consumables that you use for the minimally invasive surgery. However, it is a long surgery, but it is actually similar to that performed when you look at the minimally invasive, such as the robot cases. It's quite similar times. And there's similar rates of complications. There's a slightly longer hospital stay because when you do an open cut operation, there is always more recovery time. So there's a bit more post-operative pain and also more recovery time because you can lose, you can become a bit dehydrated as a result of the surgery, and often, in the recovery phase, you need to you're a bit depleted for different things. We need to watch you more closely. So then moving on to the different other techniques, there's minimally invasive. So in China, they've done one case of robotic as well as conventional laparoscopy. So that's keyhole surgery. And India have done laparoscopy. Sweden have actually started moving to robotic surgery, as have a lot of the European countries, as well as the US countries. So typically the teams will train with an open cut type surgery to really develop that skill, and then often they do then move on to robotic if they're in the first world or have the capacity to use a robot or do the minimally invasive techniques. So of the cases around the world done by robots, there have been 13, but the robot itself is very expensive. So it's a much more involved procedure, and the surgeons need to be trained in robotic surgery. For laparoscopy, mainly done in China and India with some success, but they're completely reliant on taking out the ovaries and using what we call the gonadal vessels. So the ovaries or the gonads, which are the precursor of the testes, which develop either into ovaries or testes, and those vessels are very good for the graft, for making sure that blood flows in and out of the graft. But unfortunately, for a donor, if you remove both ovaries, especially if they're a young donor, it has implications because it pushes them into menopause, and that has lifelong issues for the donor. So if you have a donor who's perimenopausal, we try not to take out the ovaries where we can. And then there's we can either do these procedures from a living donor, and that's where we have most of the experience. So more than 70 procedures and more live births, and I'll go through some of the rates of success. But now there's increasing interest in the deceased model, where it's a multi-organ donor. So they're someone who's passed away. They have said yes to donating all their organs, and then their family consent to then being a donor of the uterus as part of a research project, and that's what we have in Australia, where the family give consent, obviously, for that on behalf of the deceased, and it is the final organ that's removed after all the life-saving organs. And the main advantage of this, obviously, is that it's a really big operation for both the donor and the recipient, and if you take away the risks to a living donor, then that has a lot of, that's great ethically, but we're a little bit uncertain as to whether the success is quite as good as living. And so it hasn't taken off, because the first study that I went through with you, the Swedish study with the 9 patients, were done in the open model. And they found in the animal models greater success in the living donor model, but it may be different in humans. And so let's talk a little bit about outcomes. So we know that of all the transplants that have occurred, up to 20% of them need to be removed, and mostly in the first month. And this is typically because of infection in the graft, or it's to do with kinking of the blood vessel to the graft. And so if that graft survives the first month, there have been very few that have actually had to have been removed. So once you get through that more high risk first month, then you're fairly confident from a vascular perspective that it will be ongoing. Obviously, the recipient is on immunosuppressant medication, and I'll go through that a little bit more, but that puts you at a higher risk of infection, and obviously the uterus is one of the organs that can become infected and requiring a removal of the organ. Other complications, the recipient, apart from infection and the surgical risks such as hemorrhage, you can have some shortening of the vagina and stricturing, so a closing off of the vagina, making it difficult to see the cervix. And one of the things that we need to do post-operatively is to check for rejection, and that's often done by doing a speculum examination. So that's like what we do for pap smears, where you can then visualise the cervix and take a biopsy, and that we need to do that weekly in the first month, and then we taper that back as we feel more confident that the organ is functioning really well. But if you look at the success, the live birth rate per transplant procedure is sitting about 50%. So if you can actually get through that first month and have the graft not develop an infection, then you've got a 50% chance that will there'll be a success of a baby. And in fact, that's even higher. Sorry, that's the live birth rate per transplant procedure overall. It's about 50%. But if you take out of all the ones that have survived beyond the first month and of the graft success rate, it's sitting at about 66%. So it's even higher than, say, IVF, because in IVF in the community, for your first embryo transfer, and it's very age dependent, but it sits at about 30 to 50%. So if you can get through it, it's got a fairly good success rate, actually. And looking at the deceased model, so there've been 12, so using a deceased donor, so far 12 surgeries, 7 success. So obviously 5 have failed and required a transplantectomy. So the issue with the deceased donor is you don't get as much opportunity to screen the donor, because everything's done in a bit of a hurry. And so you've got a higher failure rate, typically from things like fungal infections or other infections. But if you get through without an infection or vascular complications, then overall, of the 12 surgeries performed, there's been 5 live births, so that's 41%. But if you take out the ones that were removed, then it's quite a high success rate, so a 70% chance of a successful live birth per uterus that has survived beyond the first month. And obviously there's no donor complications because there's because of the fact that the donor is deceased. So that's a really big plus of this deceased program. And I've alluded to some of the ethical considerations. So obviously it's a non-vital organ. So that's where a lot of ethicists might see that, you know, there are other options such as surrogacy or adoption. You need to obviously get informed consent. These are big surgeries for both the donor and the recipient. It's costly, and obviously in the research phase, we're covering the cost of the surgery, but and we're going to do a cost benefit analysis and write a paper on this eventually. But there's no doubt it's a costly procedure, sitting at probably around 100,000 Australian dollars. Not that we're charging in the research phase at all, because it's covered by the money that we've raised, and that's what all part of this. But when we actually cost it out, it's an expensive operation. There are obviously perioperative complications, so particularly for the donor, but it can be things like blood loss, requiring transfusion. You can have problems with the ureters, so that's the tube that goes from the kidney to the bladder, because when we dissect out the uterus, we go very close to the ureter, and there's bladder complications as well. There's immunosuppressants that the recipient needs to take for the whole duration that the uterus is there, and that we, in our study, look at having the uterus kept for 5 years, or 2 babies, or when the person has finished their family. So if a recipient says, I only want 1 child, and they get pregnant and they've completed their family after 2 years, we'll remove that uterus so that the recipient doesn't have to have the ongoing risks of immunosuppressants, such as developing other cancers and also having infections, developing other diseases such as diabetes and long-term consequences of that. In a short duration for the 5 years, there are very few long-term complications, but I think this is where this transplant is quite different to other ephemeral transplants, where they need to be on lifelong immunosuppression. This is a temporary transplant, so it's only put in for the time that you require to get pregnant, and then it's removed, which is very good. And the risks of the pregnancies are, we have a higher rate of preterm birth as well as preeclampsia. And we found that there's also an increased risk of infection causing miscarriage. So they're the main risks of pregnancy, of the very small handful of cases around the world that we've had following those 90-odd transplant procedures. So then going on to our study, so we've got a multi-site collaborative study based at the Royal Hospital of Women, and we're collaborating obviously with the team in Gothenburg, the Swedish team that had the first successful live birth. We received ethics approval in 2020. There are 3 sites, Royal Hospital of Women, Prince of Wales Hospital and Westmead Hospital, and the recruitment is mainly done at the Royal Hospital of Women because we have an existing paediatric adolescent clinic who sees patients with uterine factor infertility and especially MRKH, where I set up the first Australian support group for MRKH patients. The surgery is performed at the Royal Hospital of Women, and then delivery is either at, or obstetric care is either at the Royal Hospital of Women or Westmead Hospital, depending on where geographically the woman is closest to. The data storage is at the Royal Hospital for Women, but we are collaborating and we share our data with the International Uterus Transplant Registry. We have funding at the moment for 6 transplant surgeries in both the living and the deceased donor model, because we want to try and work out what the safest option is. We have started the study, obviously, and 2 of our recipients that have joined us tonight and will give you some of their, share their experiences with us. We've been fortunate enough to have Australia's first transplant and Australia's first pregnancy as well. So we are looking to do more fundraising. We've initially the ethics approval was for 12 surgeries, but I had to amend it down to 6 because we didn't raise enough in our initial fundraising drive, but I would dearly love to offer this to another 12 couples. So we are trying desperately to raise more funding through NHMRC grants that we're applying for, as well as putting it out to benevolent charitable funding as well. So if you know anyone who's willing to contribute to a research project, please do pass on these study details. So I've been asked to talk about the inclusion criteria because this question comes up a lot. Obviously, you need to be diagnosed with uterus factor infertility between 18 and 42 years of age, but you need to have your embryos cryopreserved below 38 years of age. So even if you're in that 38 to 42 bracket, you can be included as long as the embryos were created earlier. Obviously, you need to have a vaginal canal measuring at least 7 centimetres, and we would help facilitate that with some dilator therapy. And we've got a inpatient dilator service, the Royal Hospital for Women, which has been going since about 1990, and have referrals from all over Australia and New Zealand. The recipient should be a non-smoker because that affects your blood vessels and whether the graft will succeed or fail, or if you're not a current, as long as you have been abstinent for at least 6 months prior to the surgery. Your BMI, which is your body mass index, has to be at or below 30. You need to have had IVF before, and at our fertility and research clinic at the Royal Hospital for Women, we're obviously willing to help facilitate that, but you can have embryos created elsewhere. You have to be negative for some sexually transmittable diseases and have no active thrush infections, and you have to have normal kidney function for your age and preferably have 2 kidneys as part of the study. So for the donor, they need to match in blood type to the recipient. They need to be premenopausal or up to 60 years of age if they're on continuous hormone replacement therapy. Their BMI can be up to 35, and if they are higher, we are happy to help facilitate some weight loss because this is a modifiable risk factor, but at the time of surgery, 35 and below, to make it safer as an operation, because it's a very long operation with risks of things like blood clots to the legs and lungs, and we don't want that to happen to a altruistic donor. They can't have any previous cancers. They should be in good health and have no serious diseases or any major risk of blood clots. They need to be psychologically well and stable, and they must be willing to participate in psychological testing or consent to the study, and a non-smoker or abstinent for at least 5 years. And that's more important for the donor, obviously, than the recipient, because those blood vessels are what we rely on for the blood flow of the graft. So I guess this slide just says there is so much we don't know about this very, very new emerging science, and that's why we're doing it under the auspices of research at the moment. But once we've completed our research, I intend to go to Ministry of Health and see whether we can actually start to provide this for women in Australia as a treatment option. So it will really depend on our trial results, but we'll obviously keep you posted in that regard. And this is the community of the International UTX at a conference that we were fortunate enough to attend in 2019, just before in November in Cleveland, which we all collaborate closely, which we all learn from each other's successes and failures, and that's really helped having that great collaboration internationally. There's now a textbook on this topic, and myself and Jana Pittman, another researcher in the project, have a chapter within this textbook, and these are some of the references if you wanted to do further reading. So thank you very much.
Thank you, Dr. Deans. That was an incredibly broad and incredibly informative presentation, and we look forward to the questions that it's prompted towards the end of this presentation. Next, I would like to introduce the fabulous Kaushi Arulpragasam, our wonderful fertility fellow here at the Royal Hospital for Women, who's an integral part of the uterine transplant research team. Her expertise contributes significantly to the transplant research study, and her presence here today is to enhance our understanding of the fertility aspect of the recipient's journey. Kaushi, welcome.
Thank you, Neil, for that kind introduction. So I work as the fertility fellow to Dr. Deans and fortunate to be a part of the Fertility and Research Centre here at the Royal Hospital for Women. So we're one of the few public clinics here within New South Wales, and we see all patients for various fertility-related needs. But in the context of the uterine transplant trial, for a prospective uterine transplant recipient, as Dr. Deans already alluded to in her presentation, one of the prerequisites is the creation of embryos prior. So usually this would be a minimum of 5, and for some patients, this might include at least 1 or maybe even 2 IVF cycles to get to 5 or more embryos. Now, in terms of the process for this, here at the Fertility and Research Centre, we can facilitate the embryo creation process. And what that would involve is a GP referral for you and your partner. So the referral can be obtained online on our website, which is www.fertilityandresearchcentre.com.au. And it would be a referral for you and for your partner. And it would involve a number of investigations. So typically for the female patient, this would involve testing for your ovarian reserve, which is done in the form of a blood test and an ultrasound of the pelvis. And then we also do a blood test check for blood-borne viruses and do a blood group as well. And then for your male partner, this would be a blood test for serology as well as a semen analysis. Once this is obtained, then we will see you in the clinic and we set you up for an IVF cycle. You will have a nursing orientation and they will talk you through the administration of injection process and when to administer. Typically, this process is about 10 to 12 days, so I say approximately 2 weeks to patients, and it does involve daily injections of the hormones to try and stimulate the ovaries to try and get as many eggs as possible, and then there'll be a point when you're deemed ready for an egg collection. That would typically be done here in our unit at the hospital under sedation. And on the same day, the sperm sample would be produced and we create the embryos 5 days later. So those embryos will be frozen at our lab. And once you have received your transplant and you have been given the clear to fall pregnant, we will then subsequently do the embryo transfer. So that's just a little idea of the IVF process that is done through the Fertility and Research Centre here at the Royal. But of course, for other patients where this might be geographically challenging, we do and support the decision to create your embryos elsewhere. And I'll be more than happy to chat down the track if there are any further questions. Thank you.
Thank you, Kaushi. That was a wonderful introduction to the Fertility and Research Centre at the Royal Hospital for Women, a service that's incredible and we're very fortunate to have access to and support from. Next, I'd like to introduce everyone to Prue Craven, a passionate advocate for MRKH and a recipient of a uterine transplant as part of our research study. Prue's journey navigating MRKH and undergoing a uterine transplant is very unique. And it's a very unique perspective that we're very fortunate for her and grateful for her to share with us. It's a story of resilience and determination. And without further ado, I'd like to introduce you to Miss Prue Craven.
Hi, everybody. Thanks for joining us. So my name is Prue. I'm 36 years old and I'm from Melbourne, but I live in Sydney. I moved up to Sydney for the purpose of the transplant trial. I live with my husband, Tom, and my little dog, Annie. I was born without a uterus and I was diagnosed with MRKH when I was 17 years old. I've been married 11 years to my husband and we always knew that we'd have to undergo other methods of fertility treatment to have a family. We've been through a total of 7 rounds of IVF, so 6 rounds back in 2013, 2014 for the purpose of surrogacy in Thailand. So we have had a few attempts with some surrogates in Thailand, which unfortunately was unsuccessful. Then we went on and investigated adoption both in Australia and in the UK. Unfortunately, as we had embryos in frozen storage, we were deemed not suitable to apply for adoption for this reason, because we were considered as going through infertility treatment or IVF. Then I heard about the transplant trial in late 2019. I started the screening with my donor, and unfortunately, due to COVID, that whole process got put on hold for a number of years. During that time, I did have another offer of an altruistic surrogate in Australia who was a close friend. Unfortunately, that journey also didn't work out, as my surrogate was deemed unsuitable to have an embryo transfer. After that time, we were very lucky that COVID had settled down and the trial resumed. And that's in February this year. That's when I got into contact with Dr. Rebecca Deans, who was amazing and completely understood exactly where I was coming from. And in the space of less than a month, I was having a uterus transplant, which I had on the 10th of March. So it's been a long journey to get here.
Prue, thank you so much for sharing your story. I know there's a lot of people out there with a lot of questions for you, and I look forward to broaching that topic with you towards the end of the session. Next, joining us is Miss Kirsty Bryant, Australia's first recipient of a uterine transplant, who has recently announced the pregnancy following the groundbreaking surgery. Congratulations to both Kirsty and Tom. Kirsty's bravery, strength have opened doors for all women facing similar challenges, and her story exemplifies the transformative power of uterine transplantation, and we're eager to hear firsthand her account. Kirsty, welcome and thank you.
Hi, thanks Neil. Thank you everyone for coming, and thank you for having me. My name's Kirsty Bryant. I am 30 years old. I had my daughter 2 years ago, Violet, via emergency caesarean, and after my caesarean section, I required a life-saving hysterectomy. I was very upset about this, and 6 months postpartum, I stumbled across the uterus transplant clinical trial, and I spoke to my mum and my GP and my husband, and we went on a bit of a journey with Dr. Pittman, with Dr. Rebecca Deans and the Royal Hospital for Women. I had my 2 rounds of IVF last year, and we successfully got 6 embryos. And then this year in January, the 10th of January, I had our first uterus transplant.
Kirsty, thank you so much. We're all keeping our fingers and toes crossed for you and hoping everything's going very, very well, and look forward to seeing you again very soon.
Thanks, Neil.
Next, thank you. Next, I think I'd like to introduce Ryan Cuskelly, a trans male advocate who joins us today. Ryan's presence brings a very unique and important perspective to the discussion, emphasising the need for inclusive conversations around the uterine transplantation, and his contribution to tonight's panel highlights the significance of considering the diverse experiences within this field. Ryan, welcome.
Thank you. I'm Ryan. I'm from Sydney. I have been trying to have a hysterectomy for a few years now, and I was very close to it. I was within like weeks of having it, and the hospital pulled out because they didn't want to be responsible if I changed my mind, which kind of was a good thing, because I got put with I got to meet Dr. Rebecca Deans, who was a lot more welcoming and brought on this opportunity to help somebody else with something that I don't necessarily want or need anymore. So it's still a process for me. I'm still getting testing done and seeing who I can help, I guess. So it's very new to me, and yeah, just happy to be here.
Ryan, we're very, very happy that you're here too, and welcome. I look forward to meeting you very soon. Dr. Gertzel, would you like to move forward next into fielding some questions?
I think maybe we'll speak to Latoya, and then we'll speak with Eva Condolian, who does all our psychosocial screening. So maybe we'll move into having Latoya give her story, and talk about how she became connected in with the Uterine Transplant Program. So Latoya, if you'd like to contribute, we'd be most grateful.
Yeah, certainly. My name's Latoya. I am 28 years old, tuning in from Western Australia. I was diagnosed with ovarian cancer when I was 21, which resulted in removal of my ovaries, fallopian tubes, cervix, and uterus. So yeah, now that I've getting a bit older, I'd like to start a family with my partner. Obviously, I don't have any embryos, and I'm not able to be a part of the study right now, but Dr. Deans and Bridget have been very comforting and very supportive in regards to moving forward and supporting me on my journey in getting an egg donor, and hopefully being able to amend the ethics and be a part of this amazing trial. So I've been on the adoption journey, I've been on the fostering journey, and yeah, I'm just here to support everyone that wants to be a part of this and be a part of the research, and hopefully make this possible for everyone.
It's fantastic, Latoya. Neil, I might just bounce in for a sec.
Your story, and we're all very motivated to address the.
Sorry, Neil, I think you're breaking up. Prue, it might be quite a opportune time to perhaps maybe talk about your experience, your surrogacy and adoption experience, because I think many people may have sort of entered on that pathway towards surrogacy and adoption. And I know Latoya has gone through, as she's mentioned, a similar journey. Do you want to perhaps maybe speak about that experience? Do you feel comfortable talking about that?
Yeah, absolutely. So at the time, about 10 years ago, my husband and I didn't have any option to have a surrogate in Australia. It's illegal to advertise, and we didn't have anyone offering to be a surrogate. So we had a connection with an Australian correspondent that we met through Global Families, I think it is. And we went to a surrogacy conference and got some information on surrogacy in Thailand. So we got put in contact with an agency in Bangkok who we got matched with a surrogate. Obviously, in Thailand, the surrogates get paid for what they're willing to do. But a lot of these women are single mothers and from very low income areas. So they do benefit from this experience, and they do get very well cared for in private hospitals over in Thailand. So we underwent 6 embryo transfers with 3 separate surrogates in Thailand over the space of 2 years. During that time, I went through 6 IVF cycles so I could keep sending embryos over to Thailand. Out of those 6 embryo transfers, we got pregnant with 2 separate surrogates. Unfortunately, we miscarried around the 9 and 11 week mark with those surrogates, and it was really difficult being in Australia and having to manage that from such a long way away. So that was a difficult experience. The experience in Australia with surrogacy was much simplified by the fact that our surrogate was in Sydney and we already knew who she was. The process was quite lengthy. It was about a 9-month process from start to the point of getting to do a medicated IVF cycle. But by that stage, our surrogate was having her uterine lining checked to see if it was going to be thick enough for an embryo transfer. And unfortunately, it was not going to be viable to continue. So that that process ended sort of before it even really began. But thankfully, I am where I am today, and I think it was just meant to be that way. Thanks, Bridget.
Thanks, Prue. That's really insightful, because I know there are several people who are probably thinking about going down that trajectory, and just sharing your experiences and insights really is very helpful. And we certainly have provided some interesting links that people can reach out to if they want to receive further information about what you've spoken about. Neil, I might hand back to you.
Thank you, Bridget. Next, I would like to introduce the very important and integral member of our team, Miss Eva Condolian. Eva is our dedicated social work for the uterine transplant research study. She plays a crucial role in providing the pre-screening, the emotional support, guidance to patients and their families throughout the transplant process, and her expertise in the psychosocial aspects of this journey are invaluable. And I think it's a component that we all tonight are very excited to get more insight on. Thank you, Eva.
Oh, thanks, Neil. Well, good evening, everyone. Hi, it's so great to see so many people on this meeting and seeing our donors, our recipients on board too. I'm the outpatient social worker on the team. And look, my job entails conducting the pre and post-surgery interviews, along with the psychosocial assessments for our potential donors and recipients. So while the surgeons on the team, they're going to be looking after you medically and making sure you're medically ready, the social work partners with you and your caregivers, and we make sure that you're supported pre and post surgery so that you can be prepared as a whole. So one of the primary things we'll do as social workers, I work with Liz, she's on board at the moment. She'll do the inpatient social work and I do the outpatient. And we check how you're functioning. We look at your living conditions and how prepared you are for surgery. And we're with you pre-surgery and post-surgery. So what is entailed is we have different questionnaires that we administer, but we also do extensive interviews with both our donors and our recipients, and also with their carers and their supports. So we look at any factors that might need to be addressed early on. So we might look at lifestyle, we look at where you're working, if you are working, your finances, your travel, isolation. There may be many of you that live interstate or in more isolated areas. So we look at ways to navigate so that when you come on board, you're better able to cope post-operatively. There's a big emotional aspect to in terms of transplants. So we often are happy to refer out. So with our patients, if somebody needs an external referral, and that might be to providers in your area, we're happy to do that also in terms of your mental health. And I'm available pre and post-op, as is Elizabeth. And during your hospital stay, we'll also come in and see you and continue on with your post-operative care. And we're available by phone, email, and if you have any questions, we're always here to answer them and support the donors and the recipients. And we do have both our donors and our recipients here in the meeting today. So I just wanted to acknowledge that, and it's so great that that you're here. So if anyone has any questions, please put them in the Q&A. And if you have any questions you'd like to direct to any of our donors or recipients, please feel free to pop them on the DNA as well. Sorry, on the Q&A.
Eva, thank you so much. We are hotly anticipating a very open and informal chat this evening, so please do put your questions to the panel. I'd like to take this next opportunity to introduce Madonna Christopherson, an incredibly caring and generous woman who has provided a uterus for transplantation. Donna, would you like to talk about your experience?
Hi, yeah, sure. Bit of a surprise, this, but hello everyone. I was approached back in 2019 and asked to help Prue. Well, actually, I wasn't asked to help Prue. I offered because her mum told me the story that she couldn't help Prue, and so that started a journey of conversation and trials, and then COVID hit. We were doing really well with everything, with all the screening and everything. Everything was a match all the way along, which was really, really important. Each step was just another step closer and another step to keep us going on the journey, basically. And then when COVID hit, that was really, really hard. But we got through that and we started the journey again. And I'm glad I did. I'm glad I did what I did. I'm glad that Prue now has a uterus and is doing really well. And I can't wait to see what comes out of it. Yeah, it's just a remarkable journey, and just one that I'm just really glad that I put my hand up for and was able to partake in. So I think it's a remarkable thing, and I'm just totally blessed to have been a part of it.
Thank you, Madonna, so much. It was an honor to be working alongside you and looking after you while you were with us. And please pass on our warmest regards to your family.
I will, and the pleasure is all mine too. You guys are great, amazing, all of you.
Thank you so much. Next, I'd like to introduce everybody to Michelle Bryant, our first donor of a uterus in Australia. And Michelle, if you'd like to join us and share aspects of your story that you feel comfortable.
Sure, thanks, Neil. Thanks for having me. Kirsty and I's journey, as she said, started after she had her emergency hysterectomy. And I remember sitting in the ICU with Kirsty, holding her hand, thinking, you know, she wanted a large family, and this was now taken away from her. And as a mum, you only want to fix your children, and that wasn't something that I could do for her. So then after Kirsty approached me in regards to the trial, I was on board straight away. It was something I could do to help Kirsty. You know, I think the surgery, you know, was magical, and it was an amazing gift that I could give my daughter. You know, I think as a mum, you know, watching your daughter be a mum is just one of the best gifts in the world. So yeah, I had we both thanked the women, the Royal Women's, and they've done everything above and beyond as far as I'm concerned.
Thank you so much for sharing, and thank you so much for participating and coming down, and please pass on our warmest regards to your family as well. We did enjoy spending some time getting to know them while they were there with us. And Bridget, next, so Nick, I think, please.
I think we might move on to the Q&A section. Please, guys, this is a great opportunity to ask all your questions, not just to the clinical team, but we've got our donors and our recipients in this space with us. So it's a fantastic time. So when you're calling me up on the phone, this is your moment to ask these people all of those questions that you want answers to, as well as all the clinical questions that you would like to get explanations around. This is a fantastic opportunity. So we have one, Neil, from, I know you've got your hand up. I can't see who that is, but pop it in the chat and I'll read them from the chat if that's okay. The Q&A, put it in the Q&A at the top. So this is from Lauren. She says, hi, have you been able to find 6 donors and recipients for this trial? So I think we might pass that on to Dr. Deans to perhaps provide some information.
Absolutely. I was actually starting to type a response because I was worried about our time being short, but we are screening. So I think, Bridget, how many expressions of interest have we got for donor recipients? We've got over 100, I think, interested individuals. Obviously, a lot of people don't meet inclusion and exclusion criteria. So we're working through. One of the things that is required, and we alluded to it earlier, is that blood matching and tissue matching. So you can even be related to someone, but if you have a mother and daughter can have different blood groups, and then that then takes you out as a possible donor. So there's a few things that need to occur in order to be tissue matched, and that happens for all donor and recipient pairs, and uterus is no exception. I think another question that came in was about IVF, and yes, they all to date have been IVF pregnancies. Typically, you remove the tubes as part of the surgery. I think that this was developed because they were worried about the possibility of ectopic pregnancies, and so therefore the tube is removed to remove that risk of ectopic pregnancies.
Thanks, Beck. I think that was the IVF question that was asked. Are there any questions? Vanessa and Joey, do you want to take yourself off mute, I guess, and ask the question? Because I can't see it in the chat. Do you want to just ask the question directly to the panel? I'll direct it if you ask the question.
Yeah, just had a question in regards is it possible to have a donor that lives overseas?
Dr. Deans?
Yeah, I guess, look, theoretically it's possible, and it's certainly not in our inclusion and exclusion, but it is very difficult because unfortunately we will cover certain costs, and most of it is covered under a research budget, but a lot of screening and blood tests, particularly afterwards, make it quite difficult if you don't have access to Medicare. So I think that whilst it is possible, it's probably not preferable.
Thank you.
And thanks, Beck. Naomi Anderson, do you want to just take yourself off mute and ask a question to the panel? And I'll get Neil to direct it.
Hi, team. So I actually still have my uterus. I've got stage 4 Asherman syndrome. I was operated on a number of times by Professor Van Kai. So I was just wondering if that was an option for me to apply to be a recipient.
Yes, there has been one, I believe, for an Asherman's infertility patient. So it does put you into that category. Absolutely.
BL, I'm not sure who that is, but you might know who you are. I hope there's not
Hello.
BLs. Go
Hello,
ahead.
it's Bernard Lane. Do you have any plans to transplant uterus into a trans woman?
We have no plans at this stage, but we're obviously not we're not excluding that as a possibility to the future, but currently no plans at this point in time.
Thank you.
Thank you. Melissa, if you'd like to ask your question, and those who've asked their questions, if you could actually use your react emojis to lower your hand, that would be terrific. Thank you very much, everyone. Melissa, go ahead. Might be on mute, Melissa. We might bounce to Julie W, guest. Go ahead, Julie. We'll come back to Melissa. You'll have to take yourself off mute.
Hi, I have 2 questions. I'm an interested recipient, I guess. I had rectal cancer, and because of radiation therapy, can't use my uterus. So I guess my question is, do you have to kind of bring your donor to the program with you? I think some of the stories we've heard were sort of about people that were kind of known already to the recipients. And then my other question is, do you have to relocate to Sydney to be part of the program? Thank you.
Okay, really good questions, Julia.
Yeah, great.
So no, you don't have to necessarily know your donor. So obviously in the deceased model, you wouldn't know your donor, and we're actually looking at doing non-directed donation. So someone who altruistically, someone who could be like someone like Ryan, for instance, or like a sort of unknown donor to the recipient who puts themselves forward to say, I'd like to do something really wonderful for someone else and be a donor. So you don't have to, you can be on the recipient list without. The other question regarding relocating to Sydney, the surgery is done in Sydney. There are certain components that can be done elsewhere. So clearly the IVF can be performed elsewhere and we can transport the embryos to our unit. But in that first particularly month as a recipient is quite intense. The average hospital stay is about a week following the surgery, and then you need to have weekly biopsies, and that's the really high risk time for graft failure, and we like to really watch the organ where we can. So we have been typically recommending the recipients would stay in Sydney for at least 1 month, and then you need to come back for biopsies unless we can organise a satellite type service. And we have organised that for Kirsty, who's up in Coffs Harbour, where she's had some of her biopsies done with the gynaecologist that we're aligned to. But it really depends on where you're coming from.
Thanks,
Thank you very
Beth.
much for that.
We have Melissa. We might bounce back to Melissa if you're still with us. You're still remaining on the list of questions. So if you'd like to go ahead and take yourself off mute.
Am I here?
Yes, go ahead.
Good. So I'm actually a fertility counsellor, and this area is fascinating to me. I love that we can all do something special in this regard. I have had kidney failure myself and am on a transplant list for kidney failure, and I will absolutely donate my kidney in a heartbeat, because I know what it means to people. So yeah, where to begin? I'm really fascinated with this area. I'm really hoping that I can contribute from both a professional and a personal perspective, and want to just put my name out there as someone who can help professionally. If anyone needs counselling from fertility perspective, or I could do something to help people in general from a more practical perspective, I'm more than happy to, be a part of this. That's what I'm saying. Yeah.
Thank you so much, Melissa. Thank you. And I think we might, sorry, Beck, go ahead.
No, I was just saying thank you.
And now we might move to Madeline, if you'd like to take yourself off mute. And Melissa, if you wouldn't mind lowering your hand.
Yeah,
Got
hi,
Madeline?
thank you. I didn't, yes, that's me, sorry, thank you. I did not know how to type the question in. I couldn't see the Q&A. My question is relating to the donor age. Now, you noted that there was a cutoff age of 60. Will there be any flexibility in that? And if so, what can somebody do to best prepare themselves to get into good shape, so to speak?
Thanks for your question. Yeah, the reason that we chose the 60 cutoff is that there were some, there have been some donors who have been older, but there have been the ones that often have failed, and especially if you're a long time from menopause, because the estrogen is really important to keep the uterus healthy, particularly the blood vessels to the uterus. So someone that hasn't had the estrogen, that uterus tends to sort of shrink down, or the medical term being atrophy, and that then causes issues for the graft and whether it can succeed down the track. So I guess the second part of the question is, how do you keep yourself healthy, or as a good donor would be to keep yourself on hormone replacement therapy after, like from the time when your periods are a bit irregular and then beyond when they stop.
Okay, and if that has been the case, and I remain very healthy as much as I can and physically fit, would there be any flexibility within that 60 years to extend it somewhat, maybe? Because I understand that also family donors are probably going to be the most successful.
Yeah, I mean, often that's the case, but sometimes you're not necessarily the best match, interestingly, with a family member. And we've got ways of grading that without HLA typing. So we look at that using blood tests. Possibly down the track, there may be some flexibility with continuous HRT, and there might be some imaging that we can do to look further at the uterus and the blood vessels. We can do now MRI studies, looking MRI angiograms, where we look at the size of the blood vessels. And if those blood vessels have remained at a good gauge, then that could be possible to make an amendment.
Okay. All right. Thank you for answering, and I'll let somebody else take over now. Thank you.
Pleasure. Were there any further questions? Bridget, can you see who's...
Sorry, I was talking to the ethereal of nowhereness. AJ, AJ, welcome. Are you still online with us?
Yeah, I am.
Go ahead. Yes, we certainly can.
I wanted to write my question in the chat, but the whole time the meeting chat has said chat is turned off for this meeting.
Oh, apologies. Goodness. You can do Q&A. If you go to the Q&A, yes. There. Apologies.
Where is that? I don't see it.
It's along the top panel. It's if you look, there's chat, then people raise hands. It's usually to the right of all the icons. It's what I see on my screen.
It's next to rooms. So if you look at view and rooms, it's in between view and rooms. Do you have that function?
I don't think so.
That's okay.
Are you happy to share your question out loud?
Yeah, sure. So I want to be a donor, but I live in Perth, Western Australia. So I was wondering, would my flights and accommodation be covered for both the testing and the surgery?
So certainly for the surgery, they would be covered, and we could probably do some of the testing locally. At the moment, because we've got limited funds, we're obviously covering the costs for the surgery and anything following and around the surgery, subsequent flights to come up, because sometimes you need to come back for a second surgery to remove, for instance, ureteric stents that are placed for the donor. So there's often twice when you need to come to Sydney. But if there's pre-screening that can't be done to find out whether you could be a donor, that may need to be covered by yourself.
Okay, right.
I think we might take 2 more questions because we're running over time. But Tani, if you wouldn't mind taking yourself off mute and asking your question.
Hi there. I was just wondering as to whether there has been any time period confirmation after chemotherapy that to where the cutoff date of time period after chemotherapy to be possibly,
To be a recipient or donor?
Yes, to be a recipient.
To be a recipient. So we probably would look at 5 years as a cutoff. Yep. That would be something discussed with the oncologist, just as that's a usual cutoff for oncology to then say you're sort of beyond that risk period of a recurrence.
Yeah, okay. Thank you very much.
So Judith is our lucky last question, but if you have a look on the PowerPoint slide, you can email our team any of your questions and keep in touch with our team by going to uterine@royalwomen.org.au. So I think we'll finally finish up with Judith Fields. Go ahead, Judith.
Thank you. This has been a wonderful session. I wish we'd had it 15 years ago with my daughter, but anyway, and I did make inquiries early on, and I'm just past the age. One question I had is regarding being a donor and on an organ donation. Do you have to actually identify the uterus as an organ that you would donate, or is it just covered if your card and your wishes to your family are known?
So down the track, we may have it as an organ that's ticked off. At the moment, it's not there because this is still under research. So what normally happens if someone puts themselves up to be a multi-organ donor, the family actually give final consent for that. And then we have a donor conversation with the family to say this individual has put themselves up to be an organ donor and ticked all of these organs. Do you think they would also consent to the uterus as a organ that they would donate? And the final decision or consent would be done by the family members.
Thank you. Thank you.
Pleasure.
Beck, I'm sorry, we've just got one more that's Prue's just popped into my text and said, could we take a question from Tanvi Bedi?
Sure.
Go ahead, Tanvi.
Appreciate it. I've actually got a couple of questions. I wanted to know what the side effects we've seen from the recipients because of the immunosuppressive drugs that they're taking, and what are, I guess, the potential risks from those drugs if you do fall pregnant. And then my third question, just so many questions, sorry, in advance, is how have the recipients found the recovery in terms of working? Have they been able to go back to work? Have they had to, come up with other working arrangements and so on? How has it just worked in their experience so far? Thank you so much. I appreciate the session. It's been amazing to be here.
No problems. Do you want to take that, the two of the recipients? Did you want to take that on?
I can say, Tanvi, from my experience, I've had a lot of side effects with the medication. I'm not sure about Kirsty, but I feel like I've had a bit of a tough run, but it's all been manageable and well supported. So the side effects that come with the anti-rejections include some hand tremors, headaches, especially when the doses are higher towards the early stages. And you can get nausea, you can get lower bowel issues as well. I also developed steroid-induced hyperglycemia from being on the higher doses of steroids, which has resulted in me needing insulin. I otherwise had no other risk factors for being diabetic. It's just a side effect of the tacrolimus drug, which is the anti-rejection drug, and the prednisolone steroid. But thankfully, I'm on a very, very low dose of insulin, and it's highly likely that as the doses of steroids continue to decrease, which they are almost at their baseline, that I'll be able to come off that insulin very, very soon. And in terms of the risk to pregnancy, Kirsty probably knows a bit more about that. But from a donor recipient point of view, if your donor is positive for any viruses like herpes or CMV, Dr. Deans can probably elaborate. For example, my donor was positive for a virus that I hadn't been exposed to. There could be a number of things, but it's resulted in me needing to be on antivirals. There's no side effect as I'm aware with the antivirals, and I will be switching to an antiviral that's more compatible for pregnancy when I get to the time of embryo transfer. Kirsty, do you have anything to elaborate on that?
Hi, Tanvi. I had a pretty easier run. I did experience the headaches with the higher doses of the drugs in the beginning, but it's just got easier and easier as the drugs were tapered. When I came back to my hometown of Coffs Harbour, in the first month I was home, I have a 2-year-old daughter, and there was some gastro going around my hometown, and I actually ended up with gastro twice in the first month I was home in Coffs Harbour. The first round of gastro wasn't too bad, but the second round I ended up in hospital. And then, so other than that, I haven't really had too many side effects from the drugs that I can think of. But your second or third question in regards to returning to work. So I stayed in Sydney for the sort of 6 weeks after the transplant surgery. And once I came back home to Coffs Harbour, I just tapered my way back into work. I work as a receptionist and dental assistant extraordinaire. And I just have a really great working relationship with my work, and I just let them know what I'm most comfortable with. I mainly now do reception because I can sit down and I can, come and go as I please if I need to get up and, help myself to water or whatever I need. But yeah, I work 3 days a week and I have a 2-year-old daughter, so I'm running around constantly. Yeah, you can definitely go back to work, but I think each person is very different, and you'll just have to see what your journey entails. And as Prue said, we're very well supported. We've got lots of people to talk to, lots of contacts. If I'm not feeling well, we can call our doctors and we workshop what the best way forward is.
Yeah, and there's no doubt they're not. Sorry, Prue, go ahead.
No, I was just going to add into the work thing, for anyone that works in a more physical area. I'm a paediatric nurse and I work in a very, very busy post-anaesthetic care unit, and I actually fly back to Melbourne every fortnight to work at the Royal Children's Hospital, and I've been working since 6 weeks post-surgery. So it just shows that even despite the issues that I've had, I've recovered quite well physically, that I've been able to return to work after 6 weeks in that physical capacity. So it is possible. Thanks, Dean.
And just the final thing about the safety in pregnancy with the drugs. So we've got fairly good data because women who have kidney transplant can get pregnant afterwards and use the same sort of regime of drugs. We know that we're not sure whether the increase in preeclampsia and early delivery is to do with the drugs or to do with the organ transplant itself. So but we know that women who have kidney transplants and have these medications often have preterm births. So that will be the main sort of issue for the baby. Bridget, I think
there's two more questions. One from there's two. There's one from Rowan Richardson. Rowan, are you still with us? Are you still online? I think maybe not. May have bounced off. And Miranda Han. Miranda, are you still with us? I think perhaps both of them may have left. Well, then I think we'll just take Stacey. Stacey, go ahead, because you've been waiting for a while.
Thank you so much. I'm hopeful to be a recipient one day. I'm in rural Victoria, and I guess I have 2 questions. So my first one would be whether or not it has come up as something that might be accessible at the Royal Women's in Melbourne in the future. And my second question is whether or not there's a support group for recipients and donors, something like even a Facebook group that we can go on and have discussions or ask questions just to hear people's feedback, because I think tonight's been really great, but I think I need more.
Eva can perhaps add to that. Eva, are you on still?
Yeah, I am. Thank you so much, Bridget. Thank you for that question. Yes, that's the reason we're actually doing this as a trial, because of course there is a great demand for a donor and recipient support group. So we're actually currently in conversation with the donors, with the recipients, and also with the social worker Elizabeth in the hospital, looking at starting that up. So that's certainly something that will get off the ground in the future. If you wanted to drop an email to us, a few people, if you're in the Q&A, I've posted the email address. And if you wanted to do that, we can certainly let you know when that gets up and running. It's something that will definitely be happening in the future.
We already have a support group, actually, Eva, for AUFI under our umbrella at the hospital that Dr. Jana Pittman and myself set up some years ago to try and extend it beyond just the MRKH community, because although that is the MRKH community is a large proportion of women requiring this, there are other women as well. So we extended it to that, and there should be a website. So I'm not sure whether Dr. Pittman is still online, but I'm sure she could share the web address for that.
Oh, that would be great if you could share that, Jana, if you're online.
It's uterustxaustralia.com.au.
And the under our umbrella one, was that all part of that one?
It's all part of the same one, but we'll have to see whether there's that link that still goes through to that, Beck.
Yeah.
Jana, if possible, can you pop that in the Q&A just so that it's a few people are asking if you want to pop on. Can you see?
Yeah.
Yeah.
I'm literally just arriving for a night shift at work, so I'll try and pop in as soon as I can.
Oh, no, just
Otherwise,
if you write it into the Q&A, so you've got the website. I can write it in if you like.
And I think, Miranda, are you still on, Miranda?
Can you hear me?
Yes, we can. Go ahead, Miranda.
Yay, okay. So my name is Miranda. I'm a GP down in Tassie. I just had a couple questions for you. One, you mentioned that there's a necessity for a vaginal canal in recipients, and I didn't really understand why, because my expectation is that most babies will be cesarean delivery. And then my second question is for our trans mass communities, is there restrictions around testosterone therapy and duration of therapy or anything like that with their donation?
Yeah, really good question. So in terms of the vaginal length, because we've got the issue with stricturing of the vaginal closure, it was very hard without having a pre-dilated vagina of 7 centimetres, because you're sewing the upper cuff of the donor to the recipient's vaginal canal, and you can get like an hourglass type stenosis or closure. So that's why we try and do the pre-dilation and have a good length of vagina. Otherwise, it's very hard to do that suturing technically. And then the other question around testosterone therapy, we haven't got a duration, but we think that more than 10 years is probably going to have perhaps an impact on the uterine muscle. We would probably scan the uterus and make sure that it's of good size and can produce lining, the endometrial lining. And then we'd also look at the blood vessels as well.
Okay, so if I'm sending referrals, would you want me to have pre-done a pelvic scan on my trans-mask patients?
Ideally, yes, if they would, would happily do that. Yeah, sometimes it is a bit of an issue, and sometimes the transabdominal is okay as long as you can get those same that same information.
Yeah, thank you.
No problem.
Thanks, everybody, and for all your questions. Go ahead.
Can I take this opportunity just to thank everybody for a very involved, engaging and open conversation in the question and answers, and all of our panelists for their time, their opportunity, and for sharing what is essentially very private information and very powerful information. And I think it's been a wonderful session to progress our understanding and the broader community's engagement with the Uterine Transplant Project. And finally, the Royal Hospital for Women Foundation again, and Elise Jennings and her team, who have been incredible and generous with getting the funding that has been provided to us and supporting our participants when necessary with additional flights and expenses. And I just think that any opportunity we can to support that is absolutely wonderful. And thank you, everyone. Thank you, Dr. Deans. Thank you, Dr. Gertzel. Kaushi, there's too many people to name, but Dr. Deans, would you like to sign us off?
Yeah, absolutely. And thank you very much, Neil, for emceeing the night. Look, it's been such a fantastic contribution, and I've really enjoyed the Q&A. So maybe we should plan another one of these in the not too distant future, so that there's an opportunity to get together and keep that information flowing. So thank you, everyone.
Thank you.
Thank you.
Oh, quick, before everybody, can we just also thank the panel very much? Prue, Kirsty, Latoya, Ryan, Kaushi, of course, Beck, Keynote, and Neil and Eva. Thank you all so much. You've given up your time, hours of your time to prepare for this, and we want to thank everybody for contributing. Really a fantastic evening. Thanks, everybody.
Thanks, everyone.
Thank you.
Bye.
Thanks, y'all.
Bye-bye.
Bye-bye.
Bye-bye.